Hello, I'm Dr. Maher Abbas from Dubai, the United Arab Emirates, and it's indeed an honor and a privilege to be speaking at your conference. I would like to thank my dear friend and colleague, Dr. Padma from Moscow, for the kind invitation. Today, we will be talking and covering the topic of fistulotomy with primary sphincter repair for anal fistula. Now, fistulotomy remains the most effective anal fistula operation to date. Despite numerous operations that we have, it can yield a very high healing rate with a very low recurrence rate in the majority of patients. It's also associated with a very low postoperative septic complication rate. It's an operation that is reproducible and easy to teach trainee, and in some patients, it may be the only option for fistula treatment. However, there is the concern of incontinence. There's definitely an incontinence risk, and when we look at various studies published in the literature, the continence disturbance can vary from 10 to 49%. This also has been documented physiologically by manometry study that have shown decrease in both resting as well as squeeze pressure if we compare the patient before the fistulotomy and after the fistulotomy. Furthermore, as shown here in the picture, it can leave a fistulotomy defect, like a keyhole defect, as seen in this picture, and that can be a contributor to the incontinence after fistulotomy in some patients. These two patients from my own practice when I was in Los Angeles, this is an endoanal ultrasound. Both of these patients were referred to me with incontinence. They had prior fistulotomy by outside surgeon. And as you see on the picture on the left side, we see here a sphincter defect in both the external as well as the internal sphincter. And in this patient here on the right panel, you see a very focal small defect in both, again, the internal as well as the external sphincter muscle. Now, we do know that the incontinence risk is related to fistula characteristic. For instance, the location of the fistula in women with an anterior-based fistula would carry a higher incontinence rate. The classification, how deep the fistula, high transsphincteric fistulas will have a higher incontinence rate compared to low transsphincteric fistula. We do know the etiology. If patient, for instance, has inflammatory bowel disease, there may be some association with proctitis, inflammation of the rectum with poor compliance that can increase the risk for incontinence. There's also a patient-related factor, the gender, as we alluded to, the female, the age, the older the patient, the higher the potential risk. If they've had prior intervention like anal fistula surgery, hemorrhoidectomy, or prior childbirth, then that may increase the risk for incontinence. And also, what is the baseline continence of the patient? So for instance, patients who are diabetic or have neurologic disorders may have some degree of weakness in the pelvic floor. So the question is, does primary muscle repair at the time of fistulotomy decrease the risk of the incontinence? We do know that the sphincteroplasty is an established operation that we use for patients with fecal incontinence. These are predominantly women who've had a childbirth and were left with a sphincter defect. We can repair the sphincter defect. The operation usually is associated with very low morbidity, very low infection rate, and we do know from numerous studies that it can yield short-term benefits. And this is a cartoon showing the sphincter repair of an external sphincter defect. There are two ways we can fix these defects. One is an overlap, where we bring the two edges and overlap them. And in another type of operation, we just oppose them without really overlap. And both of them are acceptable sphincter repair option. The question, however, is how about in the setting of a fistulotomy? Because unlike a scarred sphincter in the setting of a prior obstetrical injury or laceration, there's very little data in the literature, and it's not a commonly practiced operation, and it's not accepted standard of care due to the limited scientific data associated with this. And the concern is that even though we're repairing the muscle and we're trying to make the analogy with obstetrical tear, there are, however, differences between anal fistula and obstetrical tears at time of childbirth. One is a fresh cut in the case of a childbirth versus a chronic scar. The fresh cut is in the setting of fistulotomy versus chronic scar in the setting of childbirth. In the setting of an anal fistula, as shown here in the picture, the patient is usually infected, so there's a septic risk. There's some concern that by dividing the fistula and re-repair it, that we may be recreating the tunnel track. And the question is, there may be no functional benefit. And furthermore, in some countries, there are medical legal liability. The concern that if a doctor did it and there was a bad outcome, that they may be taken for a malpractice case. Now, before I share with you the result, I would like to go over the technical aspect of fistulotomy with the primary repair of the anal sphincter. In my practice, I usually will prep the patient with 2 enemas and I will give them intravenous antibiotic at time of the surgery. Intraoperatively, I like to perform all my proctologic surgery with few exception in the prone jackknife position with the patient flat on the abdomen. You could perform the operation under either general anesthetic or spinal anesthetic. It is imperative that one identify both ends of the fistula, the side on the anal side and the side on the skin. And the fistula is completely divided with curettage, or in some cases, excising the epithelialized tract of the fistula. And then performing the muscle repair, I usually use 2.0 PDS mattress suture, and finally marsupialization of the external wound. And I will show you some cartoon and diagram related to that. And this basically demonstrates the fistulotomy technique, passing the probe from the external into the internal sphincter and dividing the muscle. And this basically shows the mattress suture. I avoid single interrupted suture because it can cut through the muscle. I feel that a mattress suture is much better to approximate the muscle. And as shown here in the bottom part of the cartoon, you see we take some deep sutures into where the fistula was to minimize recreating the tunnel. The technique is of paramount importance for the success of this operation. And this is the final cartoon showing marsupialization of the skin to minimize the size of the wound. Now, this is a hand-drawn cartoon that, again, try to emphasize why it's very important not only to do the mattress suture, but to grab with the bed of the fistula to ensure that this is obliterated so we don't create the fistula. And this is at the end, the marsupialization. You can either do a running continuous suture or single interrupted. Now, what are the results of this technique? This is my own series back when I was at Kaiser Permanente in Los Angeles. It's a single surgeon retrospective review of a 10-year experience. I practiced at a tertiary referral center. So many of the patients had complex fistulas or recurrent fistulas. And I compared here group A, which is a fistulotomy with sphincter repair versus a fistulotomy. I must say that now I routinely perform fistulotomy with sphincteroplasty, but at the time of the study, I was predominantly selectively using the fistulotomy with the sphincter repair. And how did I select the patient for the sphincter repair? These were patients where I perceived them at a higher risk for incontinence, either because they had a complex fistula, or they had a prior failed surgery, or they had borderline continence. And they had the limited option either because of significant anal scarring or stricture, or posterior-based fistula, which render a flap a difficult operation, especially in patients who are obese. I excluded in the study patients who had inflammatory bowel disease, prior radiation or malignancy, rectovaginal fistula or rectourethral fistula, which are a different type of fistulas, were excluded. If it was a very simple fistula only containing skin and fat, or a complex fistula like horseshoe fistula, these patients were excluded, and patients with an incomplete follow-up were also excluded from the study. In terms of postoperative care, this was done as an outpatient operation. Same day, they went home. All patients received 1 week oral antibiotics, especially those in Group A, and I followed the patient in the clinic until healed. The result of this study, and I would like to direct you to the Annals of Coloproctology, where I published these results on immediate sphincter repair following fistulotomy for anal fistula. This was published in 2024 in 40th issue, pages 217 to 224. The entire study with the result is shown there, and I encourage you to refer to this article for further detail. And the patient characteristic, the Group A, which underwent the fistulotomy with the sphincter repair, had 45 patients, which were compared to 107 patients with fistulotomy without repair. You see the age was fairly similar. There was a predominance of male, 80% plus were males. The Group A with the fistulotomy had more multiple fistulas. And when you look at the classification here, more patients in the Group A had high transsphincteric or suprasphincteric fistulas compared to Group B, who underwent fistulotomy alone. And when you look, about half of the patients in both groups had prior surgical intervention, including prior incision drainage of abscesses. And baseline incontinence was slightly higher, although not statistically significant in Group A. Now, this is the result. The first thing in terms of does the sphincter repair cause a lower success rate? And as you see here, 93% of the patient who underwent sphincteroplasty healed compared to 91% or 90.6% in the group that underwent fistulotomy alone. So adding the muscle repair does not decrease your success rate. In terms of postoperative septic complication, both groups were comparable, 3.7 for the fistulotomy group, 6.7 in the sphincter repair group without much statistical significance. And in terms of new postoperative incontinence, I'd like to point out that also no differences. In both groups, it was between 14 to 17%. But as I mentioned to you, the Group A, the reason I added the sphincteroplasty is that group was going to be at a higher risk for incontinence due to the patient fistula characteristic or prior intervention. How does that compare to the rest of the literature? In the same article, I basically had a summary of the studies to date that reported on fistulotomy with immediate sphincter repair. And as you see, the majority of studies report a high success rate in the high 80 percentile to 90 percentile. The dehiscence rate reported in most studies except one have been low, below 10%. Same for septic complication. The majority of studies have reported 10% or less septic complication, very similar to my study. And when you look at the postoperative continence disturbance, most studies have been very similar in the low two-digit percentages. So in conclusion, ladies and gentlemen, fistulotomy with sphincteroplasty seem to be safe for the high healing rate. The question remains about the functional outcome. We really don't have much randomized data, prospective data. Most of the studies to date published are retrospective in nature or prospective registry. So what we need at this stage is to confirm these results by multi-center prospective randomized study that compare the two groups in a prospective randomized fashion with pre and post physiologic testing. I'd like to thank you very much for the invitation and for your attendance to the meeting and your attention. If you have any further question, you can always reach out to me. This is my website, and I hope if you visit Dubai to come visit with me. Thank you very much.